Yes, got it.
And then now I'm going to make you the host again.
All
So,
right, and I'll be able to admit people in and all that good stuff. It'll come down,
yes.
correct?
Yep.
Okay. Thank you.
Absolutely. Have a great rest of your evening.
You as well. Bye.
Bye.
Uh-oh. Admit. Hi, thanks for joining. I'll give folks some minutes to come in. Hopefully, we'll get a decent handful of folks because I know how it is during the weekdays.
Oh yeah. I am gonna head home from the store. I was running errands. So
Totally understand. Because I'm like in between things too. I'm like, I was at this diversity dinner and then I'm like here, and then yeah, I get it.
all right.
Admit. Hey, Danielle. Ooh. I see you, Danielle. How's Callie doing with the
Hi.
rain? How's that
Oh
rain
my gosh,
doing?
there's so much rain. It's it stopped raining.
Uh-huh.
Still pretty wet and cloudy, so
Gross. Gross, gross, super gross.
yeah,
As we have the cold, which is like cutting through us. It's like it's so cold that like you go outside and it's just like ah.
there was so we Californians like don't know what rain is, and they said like
That's
there was 13 inches, which is like a lot for us.
ooh, that song. It never rains. But you're not in Southern California though.
I am. Yeah.
Oh, you are. Okay. Sorry. Because actually, we were in LA not too long ago. My son had a volleyball tournament, and it was fun. It was fun.
Oh,
It
where
was
were you?
50s. It was 50s, but whatever. I'm trying to think of what convention center they played in.
The downtown convention center, maybe, or
Yeah,
Long Beach?
yeah. Downtown because it was indoors. It was indoors.
Hmm.
Even though we
You should
didn't
have
make
said
it.
hello.
Oh, sorry. I was in between shifts and then I had to go to the had to go. I wanted to
Oh,
go
I get
actually.
it. I get it.
Went to the tournament and then like do this play your rah rah ree and then it's like oh back to get on the plane and then back on the shift. It was crazy. But that's what
I
I
I
do.
I totally get it. But
Oh, Selma, I see you on. Appreciate you coming. Just give them like maybe another 5 minutes because everybody's shifting through things. So
Hi,
I'll
Dr.
be
Brian. How are you?
I'm doing well. How are you?
Good, thanks.
And I forget, where are you at?
I'm in Minnesota.
Minnesota. Minnesota. I don't know why I like saying it like that. But where are you is your family in Minnesota? Where are you originally from?
Yeah, my family's in Minnesota. I did my clinicals in Chicago. I actually just got home last month.
Oh, cool, cool. Mm,
I
yeah.
like it. It hasn't snowed all. I don't know. We don't have snow this whole 2 months.
What?
It's
That's
insane.
crazy. Because don't y'all usually have snow?
Yeah, we have a lot of snow and we haven't had any.
Yeah, yeah. I mean, but we just have super cold. It's like the wind is cutting. In fact, one of my nurse assistants said that wind is so disrespectful because it just I mean, you walk out and it's just cutting you up. It's crazy. It's so crazy. Yeah. Well, let's see. Hopefully, a couple more folks will come on board. A couple more minutes. Get it to 8:05. And then we'll see. Ah, man. I worked 3 shifts in a row too. Like yesterday, I was a 7 a.m. No, let's start with Sunday. Sunday, 3 p.m. to 11 p.m. And then Monday, I volunteered to work somebody's 11 a.m. to 7 p.m. And then the next day, 7 a.m. to 3 p.m. And now I'm toast. Well, toast.
You sound like you had a good 3-day run.
I know, even though I know the young folks and residents and whatnot, they're like, look, we work 12-hour shifts and I just work 8-hour shifts. But yeah, whew, it's a lot. It is a lot.
I just finished like 3 out of 4 in a row, so I feel you.
Oh, yeah. And what time are your shifts?
My last 3 shifts were 6 a.m.s.
Yeah.
I'm just finishing up now, and then tomorrow will be like an afternoon, but we do 12s. So
Ooh. So all the attendings do 12s. But and then you have a long break afterwards?
I'm going, Cal AEM has an
Okay.
advocacy summit this weekend.
Sweet.
So I'm going to Palm Springs to help with that.
Love that.
And so I'll be off Friday, Saturday, and go back
Yeah.
Sunday.
Okay. Because I remember in residency, we would do 6 12-hour shifts. And it would be like the morning shift, like I forget if it's 7 a.m. to 7 p.m. And then middle shifts, which would be, I don't know, I'm trying to think of what they were. It was 6 to 6, I don't know. That doesn't make sense. I don't know. And then there would be an overnight shift, but then we have 4 days off after that. So I
Oh,
love,
that's nice.
I know as a resident having 4 days off, really nice.
It's unheard of.
Even though I'm thinking of the charts though, I feel like there weren't as many charts as there are now. I think there's
Mhm.
more human beings that come through the emergency department these days. So many more
They're
human
definitely
beings.
sicker, that's for sure.
That one. Well, let's see. It's 8:05. I mean, might as well get this started because I don't want to take up all of y'all's time, but I appreciate all y'all coming through. Let me share my screen. Pop this over. And yeah, we're just going to talk about just conversations. I mean, and I'll still look out for anybody coming through. Oh, let me turn that off. Make this smaller. Oh, sorry, y'all. Put this down here. Cool. Well, as a lot of y'all know, I'm Dr. Vonzella Bryant, and I'm assistant professor and assistant dean of student affairs at Boston University School of Medicine. I practice at Boston Medical Center, and also I'm past president of Women in Emergency Medicine section of AAEM. And we're just going to talk about just having a conversation. But this was an initiative that started at my medical school back in 2020. And why? Well, conversations felt a little bit heated at that time. I mean, can y'all think of like any things around that time in 2020 that was going on that and this was right before the pandemic, to tell you the truth. Yeah, lots of things are going on in the world, even though lots of things are going on in the world right now. But can anybody shout out or maybe even put in the chat what things, conversations were probably happening around 2020 as I try to figure out how to make this smaller. Let me see anything in the chat. Nope. All right. Well, I'm gonna give it to you, the stuff that was on our minds. But we just had a presidential election that, there was a lot of like, where, you know, it was said to me from my head dean, well, there's some conservatives that feel as if they can't be their authentic selves. And so, yeah, that's right there. You put it in there. And so, yeah, I mean, we got, we got to figure this out. And I was like, okay, sure, that they feel like they can't be their authentic selves and that they were nervous. but then also like Black Lives Matters, George Floyd murder, and and gosh, what am I think? Maybe, oh, well, the reproductive rights that came down a lot afterwards, and I mean, pronouns. People were like, gun laws, mass shootings are happening all the time, and there's some people who are pro guns and some people who aren't. So it's kind of like, yeah, we had a lot of things going on that some folks are like feeling very tense about, but we felt like we should still figure out how to have normal conversations. So we had these sessions where we learned how to converse, debate, coexist with our peers and our coworkers, and who don't share our worldviews. And these conversations were student driven, and that was a good part of it, because I mean, with medical school, and we want, as far as the climate, we wanted to make sure that we can try to see what we can do to improve it. And so with the conversations, we started talking about empathy. And here's one definition of empathy. Empathy is a capacity to understand others and feel what they are experiencing from within their frame of reference. That is the capacity to place oneself in another's position in someone else's shoes. I'm gonna see if I can pop this up. Does anyone else, and hey, Tiffany, thanks for joining. But anyone else want to talk about empathy? What does empathy mean to them, or what any like what their thoughts on empathy are? Anybody? No wrong answers. Or I mean, like I always say, you can put it in the chat and I will read it. Oops. If I can figure out how to get the chat, there we go. To walk a mile in other shoes. Yep. Anybody else? We could shout it out, or you could type it in and I'll read it for you. Empathy. Because I mean, sympathy, yeah, oh, I feel bad for them, but then to really try to feel where they're coming from. Oh, Tiffany, maybe if you have experienced something similar, you can help to support the other person. Yep, definitely, 100%. I can see that. Yeah. So, or even like what and I'm about to talk about the stages of empathetic listening, but I don't know. Have any of y'all heard of motivational interviewing? I feel like that is a huge thing that's taught in medical education these days, especially when we want to try to see if we can get our patients to think about doing detox for substance use disorder. Yeah, I see a thumbs up from Tiffany. Yeah, so I'm going to just go over the stages of empathetic listening, which can be really useful in our conversations. I'm just making sure in the chat there's nothing there. Nope. So approach the conversation committed to active listening. Just really, it's when we have these strong opinions, or not even strong appearance. It's kind of like when you feel like what you're thinking or your morals are right. It's really hard sometimes to try to listen to the other side, even though we're doctors, though we kind of do this all the time. But yeah, just try to really be committed to actively listening and listen to the other side of the pancake, as people would say. And then sincerely understanding and feel the feelings of the other person, restating what the other person has said to their satisfaction and reflect their feelings. Now, you know what, y'all? I've been doing this with my son. I mean, he just turned 16 about a week ago, but my son and in his relationship with his teachers, as far as I'm like, yeah, I really want you to talk to your teachers about your homework assignments, and then once you really listen, and then maybe repeat some of the things that they said so that they know that you were listening. And so I just love like how you can kind of use those tips and tricks for your kids. But it does make a huge difference, especially with our patients, for them to really let them know that we are listening to them. And I mean, with all of this, I mean, the framework as doctors, we do this for our patients, but why don't we do this for each other? And then be authentic and do not use this technique as a to manipulate others and to score debate points. So I don't know, I can't see y'all so much, but I feel like, let's see, I'm gonna see if there's any thumbs up. How many of y'all know folks who just when they go into a conversation, they just have their talking points and they just waiting just to give an answer back, and they're not even trying to listen to what you're saying. How many of y'all know folks like that? Yes, Tiffany. I mean, to tell you the truth, sometimes it could be even myself. I am not gonna lie, because I'm just waiting for my husband to say something. I'm just like, yeah, I'm gonna pull this card out and like, yeah, you said, I know. Can I get an amen? Yes, I see that. I haven't been to church in a long time, but yes, it's true. Now this Dr. Carl Rogers, a PhD doctor, but he's still a doctor. He says, we think we listen, but very rarely do we listen with real understanding, true empathy. Yet listening of this very special kind is one of the most potent forces for change that I know. And that's the thing, y'all. I mean, we want to create change. I mean, I desperately want to create so much change. I mean, not just at my institution, in my city, my town, in the world, everything. But to be able to do that, we really have to practice greater tools of listening, empathetic listening, and having these conversations so that people don't get thrown off, so that we can be able to figure out that common ground. So I thought that quote was a good quote. And so then there's this Rogerian, and I'm probably slaughtering the way to say it, rhetorical approach. And it's mainly, again, not to like debate, but to kind of come up with compromises in our conversations to figure out where we can come together and agree. So make a sincere effort to acknowledge and empathize with those holding opposing views, try to learn from them rather than dismiss them, seek common ground and mutual understanding, and restate the other's position to the satisfaction of the other. Again, restating things to make sure that the other person knows that you're listening, and then making sure you get the information right. We do that in medicine all the time. But I love that the you versus them, or even that whole diagram, that diagram is like winning and losing, but then maybe the no sum, or what is it, no sum approach, where it's like you could just find that common ground in the middle where everyone can win. And then I love this quote here. I said everything I wanted to hear. You said everything you wanted to hear. Oh, what a wonderful conversation we had. But was it though? Was that a great conversation? Not so much, not so much. And then when I think of that quote, I think of these things. I don't know, how many of y'all use the Instagram, the TikTok, the I had to remember what this was like, Snapchat. I had to type that in Snapchat, the X or tweet, or, or even the Facebook. I was so bold to put the Facebook in there, even though I know that the older generation, even though I haven't really used my Facebook that much, every now and then when I want to capture an older audience, but I don't really use it that much. But unfortunately, with these platforms, you only have the one-way conversation, and then that's just not a way to actually have a conversation back and forth so that we can figure out solutions. So actually, with our sessions, we came up with common ground rules. And let's see, I'm going to try to open my chat one more time. I mean, as far as starting up difficult conversations, like what kinds of things would you want? And like if you had like because we had tables of students, and this is kind of like a table right here. Like what kind of agreements would you want to have in having civil conversations or better conversations? And maybe you could just throw it in the chat. We can just. Oh, this is audience participation. Or well, like if we had a table of folks who you know, had a different worldview, and what do you think we would have to, what would it take for us to have a good conversation? You can be candid, but not attack anyone. Yep, I like that one. Anything else? No interrupting. 100%. Anything else? Well, let's put up like maybe about 4 more. When the person is speaking, really listen. I like that. Anyone else? I mean, Mel, I see you in here, even though you may be doing a lot of things. Maybe that's a rule. Don't call people out. Let's see. If you do not understand, ask for more information. Yeah, and that's what they lead with curiosity. That's a very important rule, especially when you don't agree with something. Leave emotions at the door. Yeah. And find a common similarity you can communicate about. Love it. Love that. Yeah. Okay. I like the framework that y'all had. No, I have to bring my Kansasness in there. I don't know how to make this smaller. It was so small earlier, and oh, okay, there we go. Yeah, there we go. That's what I wanted to do. So let me just show you what we had. These are the rules that my students came up with. I just want to make sure I can see everything that y'all have. Yeah. So we came up with come from a place of curiosity. Okay, maybe I kind of cleaned up some of the things that the students came up with just to make them sound better. But yeah, it's come from a place of curiosity. Speak with respect, no interruptions. Let everyone finish their point. No labeling of each other with terms that carry connotations and potential harm. And be mindful of our emotions and the emotions of the other people you're communicating with. And even there was something about maybe trying to diffuse things with humor. I mean, I like that, but I mean, some folks may think that you're not taking things seriously so much, but I kind of like using diffusing things with humor as well. And so we talked also about in a conversation like this, like what is the context of that conversation? You know, is there a power differential amongst the participants? So in saying power differentials, I mean, I tend to think about, you know, educator versus student or mentor versus mentee, but then there's other power differentials, right? I mean, what's some other common power differentials that y'all can think about? I would say, like, you just took the easiest ones, Vonzella. I told you this is gonna be laid back though, right? It's gonna be so laid back. Yeah, race, parents, yeah, yeah. I remember men versus women. I mean, we have kind of come a long way with, as far as women, but yeah, there's still that kind of power differential as well. Oh, and yeah, employees, religion, yeah, because I mean there are some, you know, powerful religions, especially in our country of America. And it's like yeah, that definitely it's a power differential. And then when it comes to like patients and physicians, though, to tell you the truth, like I went to it was a microaggressions workshop with was it SAEM? And it was a really great workshop. And it was about a patient who was being racist towards the physician. And we had a colleague from New Zealand who was like, "Yeah, I just tell that patient they gotta go. I just tell them when they don't want me to be their doctor, I just leave." And I'm just like, yeah, I mean, you should work with them a little bit because of that power differential. It's not like, I don't know. And y'all could tell me that I was wrong for thinking that way, but I mean, this white man telling the black patient, Aborigine patient, he said that, we'll just go. And like, which I'm using my country accent again. It just was, and that just rubbed me a weird way, And y'all can please, if y'all want to speak up and say that's not cool, Vonzella, you can totally say that. But then also, what's the purpose of the conversation? I mean, are we out to get somebody to like, I mean, are we really trying to talk it out to come up with solutions? Or are we just there to talk about just to prove ourselves to be right? So we really have to kind of check ourselves whenever we have these kinds of conversations. Oh, I was like, what is this slide for? So actually, this slide is for like, I came up with some situations which, oh, maybe I have to look at my phone, that I had the students talk about. All right, that I want y'all to talk about. Let's see. Here we go. So let me see which one I'm gonna pick out. All right. I think this is a softball one right here that I just want us to chat about. Female patient states that she only wants a male physician because of past experiences with female physicians. So how would you, like, what would you say? How would you, move forward with that conversation? And I think I do, well, I mean, if you could speak up, that would be cool, but then I can read also as well.
I'll say something if that's okay.
Yeah, please.
So I think the first thing is to try to explore, if she's willing, what happened with that last physician.
Mhm.
And if you can understand what happened and then reassure the patient that that won't happen again, based on what I'm hearing, I would say that like probably she felt like the doctor wasn't listening to her, or wasn't believing what she was about to say. She had symptoms that weren't being addressed, and so trying to listen, that way they feel heard. I think
Mhm.
that if you work in a place where you're not single coverage and the patient still feels very strongly, it's not unreasonable to consider a different provider based on the scenario. But I think in a lot of places where we work, that's not always possible.
Right.
But I think the big thing is listening, because that's usually what the problem is they don't feel heard.
Indeed.
So that would be how I would approach it.
And did y'all notice that? I mean, I could have easily. Oh, go ahead, Tiffany. Go ahead.
I was going to ask, how often does that occur, and is it
probably not as often as a female patient not wanting a male provider, right?
And what if you're listening to the patient and they still insist? What is done at that point? What does that look like?
Yeah. Well, I liked what Danielle said as far as trying to, just talking down curiosity to see if there was any like maybe whatever behaviors that were expected when having a female physician, that maybe I could reassure the patient that that's not going to happen. To tell you the truth, like I've had this situation before, and it was a female patient that always wanted male physicians, which I thought was really, because I was like one of 4 women that worked in my group at the time, and there weren't any. Well, I mean, there was, yeah, I could have just easily passed on, to tell you the truth, but I just kind of talked to her just to kind of see what was going on, why she always, what happened to her in the past. And we were able to come to common ground. And to tell you the truth, I had a male nurse assistant who I had him, because I guess we are, but back in the day, we didn't always have somebody shadow. Now I'm showing off my age, or not shadow, but be a chaperone. But yeah, I had a male nurse assistant come in with me, and then she was comfortable with that. But then when it goes the other way around, as far as a female patient not wanting a male provider, I mean, how many of y'all, give us your thumbs up, have heard that or seen that before in the past? Because I definitely have. Yeah, yeah. Of which that situation is, I mean, a little bit tricky, especially if there's hardly any female physicians that are working, or if there's no female physicians. And so in that conversation with the students, we were talking about that there should be policies in place, especially if there was some kind of sexual abuse or that kind of trauma. We shouldn't force that female resident, or even religious reasons, we shouldn't force that patient to have to see a male provider. Let me even go another layer, because I experienced this probably about 4 or 5 months ago, where I had a Black patient that didn't want any white providers. And he was homeless, and I could tell that he had mental health issues. And I could tell he probably had a lot of traumatic experiences with police or safety officers, and even my white colleagues, because of that shade that's thrown. What would y'all do for that? Yeah,
I don't
just
know. I
looking.
guess it would be a bit difficult
It
to,
would, because there's
because
not that many of us.
that's exactly what I was getting ready to say.
Yes, I'm sorry. See, I already broke that rule. Don't interrupt. Don't interrupt. But actually, this patient was fortunate to have, via the ED doc, we had a Black woman trauma attending, and we also had a Latino resident, Latino nurse assistant, but all my nurses were white. And so it was a big deal. And it was such a huge deal because my trauma attending actually asked my white colleagues to leave the room because, again, conversations. She just wanted to get the patient evaluated because, oh, I'm sorry, I didn't say. He had a box cutting cut his chest. It looked very superficial, but she just wanted to evaluate the patient, get him out of there as soon as possible without anyone getting harmed, because he did look very intent, like he could harm someone. But that didn't go over too well with my nursing colleagues, even though we did have a conversation afterwards, but it's still not going too well. I mean, as far as, that hurt, I guess, of my nursing colleagues. And even to the point with the conversation, they said something about, but Vonzella, I mean, can you believe that, or do you think that the nurses could have felt that they were marginalized white people? I thought that was interesting, but to keep that conversation, because most of my nurses get paid really well, actually, to tell you the truth. But again, not knowing their backgrounds, but I definitely felt like the power differential was definitely different. And then when I went to one of my male colleagues, docs, about it, and they said, yeah, but if it was a woman that had traumatic events with men, I mean, what do we do? I mean, it's kind of the same thing. So trauma-informed care is the other thing that I've been trying to get on the bandwagon, or to try to get out on the platforms, that we got to realize that people do experience traumas, and maybe and being able to have the conversations around that. And again, I'm not saying that I have the best answers to these things, but conversations. Let's see, let me give you another scenario. Your colleague refuses to write for Plan B and asks you to see the patient instead, because it is against his religious beliefs. Any talking points for that?
In the moment, I would probably take over the patient and handle it, but I might have a conversation with them afterwards about we have to provide care for everyone for all needs. And if we can't do that, then maybe we shouldn't be in the profession, but in a nice way.
I know, because and then it's like, yeah, it's like, but then when people say about the religious beliefs, it's kind of like, oh, yeah. And to tell you the truth, that situation happened when I was about 2 years into my practice, maybe 3 years into my practice at my hospital, and yeah, I was like, okay, okay. But, now that I've gone through a lot of things and whatnot, and like you said, and have more of the confidence to be able to speak up about it, yeah, I should have probed more. And I don't work at that hospital anymore, but probe more about that. And been like, so what's the backup for this young woman if I wasn't here? And actually, when I brought this up with the medical students in our forum with the Just Conversations, we even talked about how like maybe we can put in protocols for this, so that if there is someone that can't does it feel like it's against their religious beliefs to be able to do that, then that we can have a plan in place for what we can do for a patient that's wanting Plan B. So I thought that was pretty thoughtful conversation. Anyone else have any other thoughts on that scenario? Oh, let me see. I got a lot of no. I mean, I'm not going to give too many more. But the thing is, I mean, we talked about like patient interactions, provider patient interactions, but then that last one was about colleague interactions, like coworker interactions. But then it's like if we're able to kind of figure out ways to be able to have civil communications with our patients and our coworkers or colleagues, that, to tell you the truth, I didn't really care too much about those colleagues, but then that we need to be able to figure out how to do it with each other, and in particularly, I guess I'm thinking as a framework for the medical students, but then with each other, just pretty much in life, how can we communicate with each other better? Any other thoughts about that, as far as being able to communicate when we don't believe the same things? Like something kind of rings a bell.
I was kind of wondering, so
Yeah,
because we went through a lot of the scenarios that were kind of like, such and such patient is refusing care by such and such provider.
Mhm.
And like the ones that I've run into is, a patient is being kind of belligerent and mean and refusing care from like female providers or something.
Yeah.
And there's really there's like minimal ability to de-escalate, and the patient's not going to have a nice conversation with me about their perspective on this.
Okay.
And so like I think my usual go-to is just kind of like, this is your option. You have one option, or you can leave. Like that's sort of the like you get care from me because I'm the only one here, or you can go find another place. And I don't know if that's
Yeah.
necessarily the right approach, but that's usually the situation I'm in, rather than like being able to have an actual conversation with someone.
And what you make me think of, I mean, how are the folks around you supporting you when you're having those conversations? Because I think that's super important as well, as far as, I mean, because it happens not too infrequently, right? And having that conversation with the department, the teams, as far as how they're going to support you when a patient does that. I mean, do you feel like the patient's intoxicated and whatnot? No, they're not always intoxicated. Some of them are just straight up sexist, racist.
Yeah.
So that's why I was saying, I mean, because sometimes people are like, oh, they were just intoxicated. No. Actually, the other night I had a patient who was super intoxicated, and called me and my Black resident a nerd. We're like, oh, okay. It was a white man. We're like, okay, that's not bad. But then the other N word came out later on. It was like, oh, here we go. Here we go. But I definitely, if you haven't read that article, I think it's in JAMA, De-escalation of the agitated patient. Please read that. I mean, it has like 10 steps on how to do verbal de-escalation. And sometimes like just being calm, quiet, not yelling. And I'm not saying you were yelling, but calm, quiet, just letting them have their space. And then it tells you, even with this patient, that I just kept telling him, well, actually, at one point I was like, you should probably just stop talking because what you're saying is very aggressive and all around. I said something, but then I also kept saying, but I just want to let you know you're in a safe place. I just want to make sure, because actually this guy got beat up probably for saying the N-word to somebody out there in the street, to tell you the truth. So I was just like, kept saying it, but you are safe. You are safe. And I do say that over and over again to a lot of my intoxicated, agitated patients, just to let them know that we are not trying to hurt them. But yeah, definitely, I wish I could type that up, or maybe somebody can find that real quick. Yeah, the de-escalation of the agitated patient, and maybe put it in the chat. But it's a really good article to read through. But I think also when I mentioned colleagues supporting you, and I wasn't there, but there was an intoxicated patient who was saying the N-word, and it didn't want my Black nurse to be around them. And one of my white colleagues, allies, she stood up for, I mean, I know that sounds white savior, but was like, this is my trusted and valued colleague. Sir, we will not tolerate that. So that, that person didn't have to do the work. The nurse didn't have to do the work. And I learned that script now for even what I have, well, not for all of my white nurses, because there are some white nurses where I'm just like looking at the patient like, hey. But they're like, they're being racist. I'm just like, hey. But then if they were somebody that's like, is real, I'm like, hey, no. This is a valued, colleague. And please, let me just, let's cut that down, please. But again, I just try to be quiet and soft and in that situation where they're still, refusing to be seen. Yeah, then sometimes you just gotta let it go and hope for the best that they don't have anything serious. I mean, seriously, I've been practicing emergency medicine for like 23 years now. Sometimes you just gotta let some things go, and if it comes back, whatever. Who else wants a piece of me as far as trying to sue me? Yeah, so you'll just document like crazy. You'll document like, actually, I don't even document like crazy anymore. I just, it is what it is. But
Yeah,
lots of
I think,
time, lots of
I
times
think
stuff
usually,
happens.
usually in those situations, I usually end up with like one of my male nurses just kind of like calmly explaining to the patient the choices and that, but yeah, I'm the provider on tonight, and that's what the situation
indeed.
is.
This is what we have. But I do think it would be good for those conversations because, I mean, I remember having a resident from Afghanistan when I was at that other hospital, and a family that was just like, no, I don't want him as a resident. I mean, I wasn't there, but the resident came back to me saying that they didn't want him as a resident. And I was just like, we're not doing that today. and I mean, so they have me going in there doing that script. Oh no, he's a super smart resident. He's very smart and he's very talented. Just let him do his thing and just to let you know that you're going to get the best care. So, yeah, I'm hoping that we all can be able to get our colleagues to support us in that way. Yeah. Let's see. Oh, thank you. Thank you, Tiffany, for putting that article in the chat. Well, I mean, I just kind of wanted to go over because I mean, our job is stressful. It's stressful. It's so stressful. And it's nonstop. It's nonstop. And one of my colleagues, Beth Mazuski, she's a social worker, and she would give us talks in the ED. And the main reason I'm talking about stress is because we're in the stressful, and when people are coming at us with something that, like, I mean, I didn't even talk about what's going on in the Middle East, but I feel like I'm not even going to go there right now because, I mean, let's just come up with some basic blocks, building blocks to be able to work ourselves up, to be able to have conversations about what's going on in the world. But yeah, I like that she had this talk. She talked to us about just having stress in the emergency department, and the green is for ready. Like, I'm ready to learn and work and whatnot. And I love how with green, you're coming from a place of safety, feeling everything's neutral, and yeah, you have the knowledge and resources. You feel like everything is great in the world, sense of joy, and ready to work with others. It's yay. But look at, and this is supposed to be our breathing pattern. Like, yeah, nice press. But then when we become reactive in that yellow, and it's like heart beats faster, and we start breathing little bit weird up here. Our skill sets kind of slipping and feel a little bit helpless, isolated. I don't even know why there's two more of these, because I mean it all goes downhill. I mean, when you get to injured and you feel stuck and you're just dysregulated, and your breathing pattern is just really super crazy. You start having fatigue and headaches. I mean, I'm just going through this because, we got to take care of ourselves, especially this. It's like, boom, done, you're stuck, we're on red. But the thing is, showing us this and our responses to things is just telling us, like, when giving us the symptoms of, like, hey, if you notice that you're feeling this way, you need to figure out or to do something, or you need to be able to communicate with your colleagues that you need to take a pause. And so with that pause, um, I was going to say, like, she taught us how to do this box breathing. And let me see if I can see y'all again. I mean, have any of y'all done the box breathing yet? We breathe in 4, hold 4, breathe out 4, and then yeah, breathe out 4. Actually, I did that with a patient who came in for chest pain, but I did all the things that we have to do for chest pain because, that's what we do in the emergency department. But I really felt like he was stressed and panicky. And so I told him to do this box breathing. I was like, just do the 4, do the 4, do the 4. And then a couple of years down the road, I went to a conference, and this woman was like, hey, you took care of my husband in the emergency department who was having a panic attack. Which I was like, uh-oh, was he though? Or was he having a heart? But she's like, no, he was just having a panic attack. And you taught him how to do that breathing. And I was just like, oh, cool. I didn't kill him, yay. But yeah, I mean, it definitely was super helpful. And it was like, yeah, I mean, that works. And actually, there was another woman that I worked with who works in our communications world. She's like, can you teach me how to do that? Because she's super stressed too. But then also, we were taught when things get stressful, and I found this to be super helpful for me too, is to just get me a cup of water. I got a cup of water, because what happens when you get a cup of water? You take a pause, and then when you drink that cold water, your regulatory system just kind of calms down and cools off, and then you can think better, and maybe you can get yourself from orange back to yellow or something like that. But then the other thing is to, like, maybe take a walk. I mean, I'm always telling my residents, I mean, because that's the thing, we're emergency medicine doctors. We're supposed to be superheroes. We just keep working, 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 working. We don't pee, we don't eat, we just keep work. No. I mean, maybe because I'm 50 and I'm just like, and I'm not working, I'm working with residents now. So I feel like I am able to take more pauses but then I feel like as an attending with these residents, I need to get my residents to take a pause. So, hey, go get some lunch. I can take care of the phone calls that are coming in, the consult calls and whatnot. Go to work. Okay, I'm not putting in ultrasound IVs because I suck at that. But I will type up your discharge papers for that patient and whatnot. but I do think the culture has to change where we have to be able to get each other to take these breaks and take a pause, take a walk. And when you're taking a walk, imagine that you're walking in this forest, which looks really, really cool. Oh, by the way, does anybody else have any other tips that they do when they are feeling kind of super stressed or whatnot? What do y'all do when you're kind of feeling like, I mean, especially, yeah, emergency medicine is crazy. I mean, we do a code for like 2 hours, then we go back to see a belly pain that was like, I've had this belly pain for 6 months and my CAT scan was negative and my colonoscopy was negative. And it's like, oh, okay. Yeah. Yeah, walk away with deep breaths. Yeah, I go take a nap. Yeah, back in the day, man. In fact, one of the older docs that I worked with at the other hospital, he was like, yeah, Vonzella, or overnight shifts, you gotta take a nap because if you don't, most medical errors happen in the morning. I'm like, you can't do that anymore. There's so many patients. Unless you work in a facility where you can. But yeah, there's too many patients. Too many patients. But yeah, let me look to see what else I got for you. Oh, so this here, this goes back to the conversations. I mean, and the last segment was about like, yeah, was kind of stress and whatnot, and then to get involved. Oh, because the other thing that really irks me too in my emergency department is that I have nurses that wear these, they're not Blue Lives Matter shirts, but it's like, oh, canine puppies, and they have paw prints. They have like those Blue Lives Matters kind of print in there, like the blue line and whatnot. Or there was like a t-shirt for autism. Yeah, it was the Blue Lives Matter, which I'm like, so I mean, you're working and you're like, but the patients I serve, a lot of them, not all of them, have bad experience with police officers, and then you're gonna like just shove that in their face, and it's just like ah. But take a breather, take a pause, drink some water. Whew, maybe try to jab at them a little bit, like, hey, do you realize that a lot of our patients have bad experiences with police officers, and that may make them feel uncomfortable? If you feel like you can have that conversation after having a pause, I mean, yeah, yeah. That's the crazy life that Vonzella has to go through. But I'm pretty sure that some of y'all experience similar stuff. But the cancel culture, of which I'm not saying is a bad thing. There are some folks that do need to be canceled, don't get me wrong. Or just like my husband, who's in pediatric hematology oncology, and I would talk about emergency medicine doctors being sued all the time, and oh, that sucks. But then actually, I think about it, there are some people that should be sued because they have, like that one doctor that was giving cancer treatment to people who didn't have cancer and they were losing their teeth. I mean, okay, some people need to be sued, but other times I do think it's a little bit over the top. But the cancel culture, though, again, doesn't give a chance for folks to learn and grow. And which I hope that even when I make mistakes and errors, that folks will give me another chance to learn. So that fixed mindset, like if we say, oh, I can't believe you didn't, I'm trying to think of an example. I don't know, maybe with the pronouns and whatnot, you know, no, don't do that to folks. Just kind of be a little bit more gentle to call people in. I mean, after a whole bunch of times that if they're not getting it, I got it. Okay, you're done. But if we don't like come at them hard and cancel them, maybe there's gonna be a chance that we can just kind of celebrate growth mindset that okay, they didn't get it, but we're all learners, like lifelong learners, and maybe they will get it at some point. So I just wanted to point that out. I know I just like this picture because it's beautiful growing. And oh, I forgot what I had this slide for, but maybe it was just more of what y'all's thoughts are, because this is pretty much the end of it. The end of it, the end of the talk. Any thoughts? I mean, I know I didn't go deep into specific difficult conversations, but I'm hoping that you know we can kind of ripple this out to other folks to have to start to talk about how to have civil conversations. All right. Yeah, we are not alone. Yeah, actually, I'm part of NMA affiliate chapter here in Boston, and we have this white coat trauma sessions, and we had one last night, and usually one person talks about something that they experienced, and it's just when you hear everybody else saying, "Oh yeah, I had that, and this was what I did," and then even to say that you didn't do anything thing wrong, that the culture needs to be changed, and yeah, it's these types of things are very helpful for our wellness to go back to community. We always have to go back to community. Thank you. Thank you all. Well, like they always say, may I'll give you 10 minutes back whenever you end early. But I hope that it was helpful, and I appreciate all you guys for joining in. Any other comments or questions or anything? Or please reach out to me. I guess I gotta show my email again. um, so that you can email me if there's anything else. Oh, Vonzella. Maybe I'll just stop my share and just put my email address in here if y'all want to chat about anything else. Cool, cool, cool. How'd I do, President Daniel Goodrich?
Awesome. That was great. Thank you so much for speaking. And those examples were super helpful to help us think about how we would approach those situations. So thank you.
All right.
I
Appreciate
guess I do
all
have
y'all.
one
Yes,
question.
yes, please.
And no one has to stay if you don't want, but what do you all, besides the trauma sessions that you hold with your colleagues,
Yeah.
which other coping mechanisms would you recommend? What else is there to do since there's not a lot of time to, maybe go for a walk when you're on that shift or go take a nap or anything like that?
Right, right. Because like I said, you know what I end up doing, which I don't know, I forget. Tiffany, are you a resident, a medical student, or
I am
what are you?
a postdoc
Full
research
faculty?
fellow.
Oh, yeah, yeah. Because to tell you the truth, again, community always helps me out when I'm at work. So what I mean by that is that I am like one of the only Black doctors, besides the Black residents that we recruited, but they're not always there and they're kind of out and about. But my coordinators, my transporters, my translators and whatnot, um, I always feel like when things happen that I thought was crazy, I was like, well, I'm kind of talking kind of out of pocket there. And then I just go and find somebody in the department, just start chatting away about something. And that always makes me feel better. And I'm able to push forward, even with patient conversations too. I mean, I grew up in Kansas City, Kansas, and country, and when we eat chitlins back then, even though I haven't eaten chitlins because I don't know who's cleaning those pig intestines, and I really, except for my mama, this is my mom. But talking with patients about some shared experiences are really helpful for me with my wellness to keep pushing forward and moving forward. I don't know. Other y'all have any other tips? Oh, and then plus I finally got a therapist that I trust and I like. So
I'm very similar. Oftentimes I will like reach out to a colleague and just say like, I need to vent for 2 minutes and step outside and just go through it and like get it off my chest. And if that person's not there, sometimes I'll call that person after my shift or the next day. I also find that journaling has been really helpful for me
yeah.
to get things off my chest and decompress. And along with a little like meditation breathing, I think that,
Yep.
I can help the situation. So,
Oh, and you know what? Actually, the session I had with my group yesterday, we breathed in a word. So, for instance, one of my colleagues, she said that she struggled when she was in her training with feeling that people didn't think that she was smart enough and that she wasn't talented enough. And so the word that she breathes in is brilliance. And so he's like, I am brilliant. And then you breathe out whatever that other stuff was, but breathe in something as a word. Another woman breathed in, I am enough. And another one, a physician breathed in, I am destined. And I was just like, yeah, those are powerful words for us to breathe in with our mindful breathing.
Thank you.
Yes, please. All right. Anything else, y'all? Cool. All right. Well, have a great rest of your night, and thank you for the opportunity. That's what I was supposed to say at the beginning, Danielle. Thank you. Thank you for the opportunity. Take care, everyone. Bye.